Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official. Today in this video, we will discuss investigation of anemia, which is the competency advised by the NMC, National Medical Council of India, for making a Indian medical graduate according to curriculum-based medical education. Let's start the video. In a case of suspected anemia, first you have to estimate the hemoglobin or packed cell volume. If the hemoglobin is less than the normal according to age and sex, then you can consider it as anemia. Okay, then you have to check for the signs, symptoms, peripheral blood smear, reticulocyte count, red cell indices MCV, MCH, MCHC, and even red cell distribution width. Then you have to do the morphological classification of anemia and probable cause of anemia. With the with that, you have to do again perform special laboratory tests to establish the cause of anemia. This is the flow chart or the pattern to be followed in investigating a case of anemia. For a case of normocytic normochromic anemia, first you have to advise for a reticulocyte count. If the reticulocyte count is increased, it is mostly because of hemolytic anemias and acute blood loss. And if it is low reticulocyte count than the normal, infection, inflammation, malignancy, or chronic renal disease can be suspected. To confirm it, whether it is yes or no, you have to do bone marrow examination, whether infection, inflammation, malignancy, or chronic disease, renal disease are not present. You have to go for bone marrow examination and confirm whether it is aplastic anemia or anemia due to marrow infiltration. If infection, inflammation, malignancy, or chronic renal disease is present, you can confirm the diagnosis as anemia of chronic disease or of chronic renal failure. Normocytic and normochromic anemia MCV will be within the range of 80 to 100 femtoliters and MCHC will be in the range of 30 to 35 gram per deciliter. And reticulocyte count, if increased, it is mostly because of hemolysis or recent blood loss. And if reticulocyte count is low, it is aplastic anemia or anemia of chronic disease or anemia due to infiltration of the marrow or chronic renal failure. Microcytic hypochromic anemia MCV will be less than 80 femtoliters, MCHC is less than 27 picograms, and MCHC less than 30 gram per deciliter. Microcytic hypochromic anemia may be because of the sideroblastic anemia or anemia of chronic disease or thalassemia or iron deficiency anemia or lead poisoning or porphyrias. To diagnose these diseases, first with a peripheral smear showing microcytic hypochromic anemia, you have to advise first test is serum ferritin levels. If the serum ferritin levels are very low, then you can confirm it as iron deficiency anemia. If the serum ferritin levels are normal or increased, it can be thalassemia or anemia of chronic disease or sideroblastic anemia. Then to confirm along these diseases or among these diseases, you have to advise for hemoglobin electrophoresis. If the hemoglobin electrophoresis is normal, it is because of anemia of chronic disease or sideroblastic anemia. If it is abnormal hemoglobin electrophoresis report, then it is thalassemia. To rule out the anemia of chronic disease from sideroblastic anemia, you have to advise for a bone marrow iron stain, that is PEL stain. If the storage iron is increased, then it is anemia of chronic disease. If you observe ringed sideroblasts in the PEL stain in a bone marrow, then it is confirmed as sideroblastic anemia. Coming to macrocytic anemias, the MCV will be more than 100 femtoliters. MCHC will be normal around 30 to 35 gram per deciliter. The causes for macrocytic anemia can be megaloblastic or non-megaloblastic. Megaloblastic causes include folate deficiency or vitamin B12 deficiency. Non-megaloblastic causes are alcoholism, liver disease, hemolytic anemias, myelodysplastic syndrome, hypothyroidism. So when you observe macrocytes in a macrocytic anemia case or in a peripheral blood smear, then if you advise a reticulocyte count, if it is increased, then polychromasia and evidence of hemolysis will confirm it as hemolytic anemia. If the reticulocyte count is normal or low, and if it shows oval macrocytes, then it is non-megaloblastic anemia because of liver disease or alcoholism or hypothyroidism. If there are low or normal reticulocyte counts and round macrocytosis is seen, there is dyshematopoiesis, then it is confirmed as myelodysplastic syndrome. If there is normal or low reticulocyte count, macrocytic blood picture, and there are oval macrocytes, hypersegmented neutrophils, and these hypersegmented neutrophils are having 5% of the neutrophils are having hypersegmentation, then it is megaloblastic anemia. Coming to features of hemolytic anemia. Hemolytic anemia will be having low hemoglobin than the normal range. There will be raised reticulocyte count and there will be raised indirect serum bilirubin. These three are considered as features of hemolytic anemia. One is low hemoglobin and the other two will be raised. Reticulocyte count raised and indirect serum bilirubin will be raised. When you observe the blood smear, if you found sickle cells in the peripheral smear, then it is a sickle cell disorder. If spirocytes are seen, the disease can be autoimmune hemolytic anemias or hereditary spirocytosis or ABO incompatibility hemolytic disease of newborn. If there are schistocytes in the peripheral smear, then definitely it is MAHA, microangiopathic hemolytic anemias. If you observe white cells in a peripheral smear, then it is glucose 6 phosphate dehydrogenase enzyme deficiency that is causing anemia. If there are microcytic hypochromic cells and target cells, then it is a case of thalassemia. If there is low RBC count, low WBC count, and low platelet count, that is pancytopenia on the peripheral smear with features of hemolytic anemia, then definitely it is a case of paroxysmal nocturnal hemoglobinuria, PNH. And if you observe a blood smear, if you found gametocytes or ring forms, then definitely it is a case of a malarial parasite that is causing the hemolytic anemia. So in a hemoglobin electrophoresis, when we observe in various persons and patients, in a normal newborn, the hemoglobin F will be more compared to hemoglobin A, and hemoglobin A2 will be in minor, less than 1% of cases, and there will be no HbS. In normal adults, it will be HbA 97% and less than 1% will be HbF. Around 1 to 3% will be HbA2 and there will be no HbS. In a sickle cell trait and in a sickle cell anemia, there will be HbS. So HbS will be 90 to 95% in sickle cell anemia, whereas it is 40% in sickle cell trait. And there may be hemoglobin F or hemoglobin A. Definitely there will be hemoglobin A too. In beta thalassemia minor and beta thalassemia major, there will be no HbS, but HbA will be 90 to 95% in beta thalassemia minor, whereas HbF will be more in beta thalassemia major. So, anisocytosis is variation in the size of a cell. It can be, red blood cell can be described as normocyte, microcyte and macrocyte. Normocyte will be having MCV in between the range of 80 to 100 femtoliters. Microcytes will be having the MCV less than 80 femtoliters with decreased amount of hemoglobin. Causes will be sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, lead poisoning, porphyrias. Macrocytes will be the large red cells with MCV more than 100 femtoliters and the size will be around 8.5 microns or more than that, and the MCH will be normal. They can be round macrocytes or oval macrocytes. Causes will be impaired DNA synthesis in B12 and folate deficiency, accelerated erythropoiesis, excessive surface membrane in liver disease or splenectomy cases. Poikilocytosis is variation in the shape of the red blood cells as seen in various conditions. Among them, thalassemia is the most commonest one. Target cells, which are also called as podocytes. These are flat red cells with a central mass of hemoglobin, which is a dense area, surrounded by a ring of paler area, and an outer ring of hemoglobin, again dense area. So there will be central ring of pallor, outer and inner there will be a dense area. This is a classical feature of a podocyte or a target cell. Target cells are seen in iron deficiency anemia, chronic liver disease, hyposplenoism, and in hemoglobinopathies. Polychromatophilia or polychromasia. Red blood cells staining bluish gray. They will represent the young reticulocytes and are seen in the conditions associated with where there is a need for excessive erythropoiesis or accelerated erythropoiesis. Punctate basophilia or basophilic stippling. Presence of fine or coarse purple blue granules in a cytoplasm of a red blood cell which are representing ribosomal aggregates are called as punctate basophilia or basophilic stippling. And this is a characteristic feature seen in beta thalassemias, hemoglobinopathies, lead and arsenic poisoning. Coming to Howell-Jolly bodies. These are remnants of nuclear material left after the nucleus is extruded in a red blood cell. These are normally removed by a spleen. Causes will be non-functioning or absent spleen, because of which these are not been removed, and in megaloblastic anemias, these Havel-Jolly bodies are seen. Coming to hinge bodies, these are formed from denatured aggregated hemoglobin. Cells contain hinge bodies are normally removed by the spleen and they do not stain with Romanowsky stains. They can be demonstrated with the help of supravital stains like new methylene blue, brilliant crescel blue, or brilliant crescel green. Causes for hinge bodies will be thalassemias, asplenia, and chronic liver disease. Spherocytes, these are densely hemoglobinized or dark appearing red blood cells with no central pallor. In generally, there will be central one-third of the diameter of a red blood cell there will be pallor in a normocyte. Here you cannot appreciate central pallor. There will be no central pallor. So normal or decreased MCV, and there will be increased MCHC. So the red blood cell will miss its biconcave shape and become spherical or spherocyte. Causes are immune hemolytic anemias, hemolytic disease of newborns, burns, and a classical example, hereditary spherocytosis. Coming to sickle cells, these are also called as drepanocytes, curved red cells with pointed ends. Looks like a sickle. Causes will be sickle cell anemias and a sickle thal or HBS beta thalassemia case. Teardrop cells are dacrocytes. Dacro means tear. Okay. Teardrop cells are dacrocytes. These are red cells in the shape of teardrop. They are pathological and should be followed up. Causes will be infiltrative disorders of bone marrow like myelofibrosis. They can be seen even in megaloblastic anemias, beta thalassemias, renal failure, and tuberculosis. Cystocytes are nothing but fragmented red blood cells. It is because of mechanical stress like in microangiopathic hemolytic anemia or MAHA, or it can be because of thermal injury or severe burns. Echinocytes, also called as sea urchin cells or burr cells. These are small cells or cell fragments bearing shorter, more regular spines, 10 to 30 in number, evenly spaced. Don't confuse with cystocytes. Causes will be uremias or pyruvate kinase deficiency or blood storage for a longer duration, ATP depletion or calcium accumulation, and even contact with glass will result in echinocytes or burr cells. Elliptocytes, the name itself is saying elliptical cells. The causes are hereditary elliptocytosis, thalassemia, sickle cell trait, iron deficiency, megaloblastic, and myelophthic anemia. Bite cells. Red cells with peripheral single or multiple arcuate defects or bites are called as bite cells. And these are seen in red cell enzyme defects like G6PD deficiency and pyruvate kinase deficiency. When you are hungry, you will eat, you will bite. So remember glucose, energy, bite, bite cells. G6PD deficiency, classical will be bite cells. Acanthocytes, also called as spicule cells or spur cells, these are spheroidal red blood cells with a few spiny or thorn projections, and they are 5 to 10 in number. Remember, in echinocytes, it is 30 in number evenly spaced. Here, 5 to 10 in number with irregular thickness and spacing. Causes will be post-splenectomy, alcoholic cirrhosis, pyruvate kinase deficiency, autoimmune hemolytic anemias, AIHA, severe burns, and renal disease. Coming to stomatocytes, these are uniconcave red blood cells with a slit-like area. Stoma means slit-like area of central pallor. Causes will be hereditary stomatocytosis, alcoholism, cirrhosis, obstructive liver disease. When we are discussing about red blood cells, you should be thorough with agglutination and Rayleigh formation. Rayleigh formation is red blood cells arranged in like stack of coins. True agglutination is irregular clumping of the red cells into grape-like clusters. Rayleigh formation is also called as pseudo-agglutination. It is observed in paraproteinemias, hypergammaglobulinemias, and fibrinogenemias, which are causing stacking of red cells. So this is a beautiful picture are drawn by me at the time of my PG teaching the UG students. Microcytic hypochromic anemia and macrocytic anemia. For a undergraduate or for a postgraduate, definitely if you are going to write any investigation, first you should be thorough with the normal ranges. So everyone should learn or by heart these normal ranges at any cost. Whatever your mind knows, that only your eye sees. So first you memorize these normal ranges so that you can identify the abnormal things which will help you in diagnosing the disease and treating the patients. This is a picture showing the complete blood picture that is done with the help of a automation hematoanalyzers showing the various RBC, WBC and platelet counts and red blood cell indices and their graphical representations. Thank you for patient listening. Before concluding, I will say read everything before you do anything and read everything carefully before you do anything. So I have underlined read. So first you have to read. Don't come to a conclusion. First read, then do. Okay? The way you do one thing is the way you do everything. This is a lesson or quote learned from my Guru Rashekar sir. Okay? So how you are doing one thing, you will do all the things in the same way. So as a student, you have to learn the things, then only you can treat the patients. So if you are thorough in learning and thorough in practicing the things, you will be a best doctor. Thank you for your patient listening. Again, please like, share and subscribe Dr. Ravichandra Official for more interesting videos.